your allergic reactions and anaphylaxis, there's a very good chance that that patient's going to have an immediate life threat. And if you think about the onset of anaphylaxis, which, we're looking at maybe a minute, 30 to 60 seconds, by page out time, let's say somebody recognizes there's a problem, so you call 911. It takes probably about a minute, minute and a half to put in information in the computer system and dispatch out a unit. Then it takes another minute or two for that unit to get to their vehicle. And then it takes however long to get to the place where the patient is. So there's a whole lot of steps in the way between them and help. And we know that anaphylaxis can kill somebody very rapidly, so because of this, we have to be able to recognize and act very rapidly once we decide that there might be an allergic reaction or anaphylaxis going on, because it truly can be a difference between life and death. So some things we want to look at, is this an allergic reaction or is it anaphylaxis? Occasionally it can be caused by a substance that may be a risk to other people like us, the providers. Bee and wasp stings usually are from one insect, but sometimes it can be from a swarm. And you can even, when you have a lot of stings, even patients who aren't allergic can still become very ill. So if there's a swarm of bees going around, don't enter the scene. That scene is not safe. Okay? Figure out who you need to get to help and request those resources. Some other times, that substance may not pose a hazard to you. So then we're going to go and make sure that that patient's not still in contact with whatever that substance is, because the more they're exposed to it, the worse their reaction or their condition is going to get. So we're first going to look at them, and we may get some immediate clues that anaphylaxis is happening, like swelling of the face or tongue, hives, stridor, wheezing. Those are all big neon signs that say anaphylaxis over here. And we're going to determine from the patient or from the bystanders what happened and how long has it been happening. How fast did the reaction occur? Generally, you're looking at 30, 60 seconds, but it can be delayed up to even an hour sometimes. But generally, a good rule of thumb is the more rapid the onset, the more severe the reaction is going to be. So, primary assessment. If they appear unresponsive and they're not breathing, check for a pulse. If there's no pulse, we do CPR, right? Follow CPR. Otherwise, we're going to assess their airway very carefully. If they have stridor, that means that their airway is being narrowed by swelling. Even if you don't hear stridor, suspect that the tongue and airway tissues may be really swollen if their face and lips are swollen. So they could still become a problem. Anaphylaxis can cause enough swelling to actually cause a complete airway obstruction. Alright, and what this does is it makes your normal approaches to airway management not work, and sometimes even causing more problems for the patient. If you insert an airway adjunct in there to swollen mucous membranes, it's going to result in probably bleeding and some increased edema, which is the exact opposite of what we want. Non-visualized airways, such as a combi tube or supraglottic airway, they don't provide direct passageway into the trachea, so they're not going to be an adequate solution to your airway edema as well. So unless you can perform an endotracheal intubation in your scope of practice, it may be better just to use manual airway and BVMs. Alright, if they have an impending airway obstruction, the person with the best intubation skills should be doing the intubation. Whoever's the best at it, this is not the time for pride. Alright, it's going to be difficult. And if you are not good at it, then it could cause some increased airway edema. And, beyond that, the last-ditch kind of effort is the cricothyrotomy. So if a paramedic response is available, request them. Have them come meet you. If they're not available, prepare to transport immediately to the nearest ER. Meanwhile, we're going to be looking for signs of respiratory distress. We're going to be looking for wheezing, grunting, drowsiness, accessory muscle use, cyanosis, all these things. We're going to use a BVM for patients whose breathing is inadequate. We're going to give them supplemental oxygen as needed. And we're going to look for signs of hypoperfusion. With anaphylaxis, your patients are going to have a problem. By definition, they're going to have a problem with an airway, a breathing, or a circulation. Their mental status is probably going to be altered, and they're probably going to be hypotensive and tachycardic. Right? Most of the time, there'll be some sort of history of anaphylaxis and a known history of exposure. Now, for non-critical patients, do your focused history and your physical exam. Check for your edema and urticaria. Get your vital signs. Use your sample and your OPQRST. Make sure you get all the pertinent information about the problem. And then frequently reassess. For your critical patients, We're going to defer that detailed history and exam until you've performed any interventions needed for your A's, B's, or C's. Then we're going to do a rapid medical, including breath sounds, get your baseline vitals, and continue to reassess with that patient. The signs and symptoms with anaphylaxis are pretty obvious usually, but they're not always unique to anaphylaxis. But by definition, this anaphylaxis is life-threatening, so always carefully assess and reassess your airway, your breathing, and circulation. With this, these patients, like I said, they usually know they've got a problem. My 12-year-old son, he's allergic to everything. Like, the world wants to kill him. He's allergic to trees. He's allergic to grass. He's allergic to, which those just give him sniffles, pretty much make him all wheezy and swollen. But he's also deathly allergic to nuts. He has anaphylactic reactions to pretty much all nuts. And so he's very careful about looking for these things. He reads food labels, and if he sees anything that even remotely says may produced in the same facility as something that does tree nuts, so he won't eat it because he doesn't want to have to get a bunch of shots. He doesn't want to have to get the IV and go to the hospital. But they've got to be aware, but we've got to be highly suspect of these different types of allergic reactions and be able to recognize them very, very rapidly. Your allergic reaction and anaphylactic reactions are also known as a hypersensitivity reaction. Now, you've got, at one end of the spectrum, you've got a mild allergic reaction, and on the other end, you've got a severe life-threatening anaphylaxis. In both cases, the body's been exposed to an antigen, all right, and we also, this is the allergen, but normally it doesn't provoke an immune response. Like, I can go see a tree and pick up a leaf and it doesn't do anything to me. The body's normal. But some people's bodies, they develop this memory for whatever this antigen is, and they're sensitized. And then this is the primary response. Now, so what happens is on each subsequent exposure, you're going to have a rapid response to that antigen, and then it's going to get more severe. It's going to continue on the more that you're exposed to it typically. Now, on the milder end of these reactions, they're called delayed cell-mediated hypersensitivity reactions, and this is going to be caused by a T-cell response. And this would be like poison ivy, where you don't have a rash that develops for several hours after exposure to the plant. In other cases, these antibodies are produced by your B cells, and these are carried by mast cells and basophils, and these are going to bind to the antibodies, and it's going to produce this significant reaction. And this is called an immediate hypersensitivity response. And some of the more common causes of these responses are going to be drugs like antibodies, foods like peanuts, sesame seeds, shellfish, things like that, insects, bees and wasps, and some toxins. Now, toxins in general, antigens can get in the body in a lot of different ways. This may be ingestion, inhalation, injection, or skin contact. There are two other similar types of anaphylaxis that are not quite anaphylaxis. So you've got anaphylactoid, and this is going to occur most often in dyes that are used in radiological procedures or iodine, things like that. Your signs and symptoms are the same as anaphylaxis, but it's not the result of an IgE binding to an antigen. Another situation would be angioedema, and this is more common with ACE inhibitors. And basically what happens is these ACE inhibitor reactions can cause an acute onset of angioedema due to vasodilation and increased vascular permeability. Right? But this is pretty much contained to the mouth and the tongue. Could still be a big problem, but it's not swelling everywhere generally. Now, comparison between mild allergic and anaphylaxis. Your onset. Allergic reaction, usually slower, more gradual. Anaphylaxis, usually rapid. Skin. With a mild reaction, you'll have some itching, some hives, localized. With anaphylaxis, you'll have itching and hives that may be widespread. Typically, you'll have diaphoresis, may be flushed, may be cyanotic, and you'll have respiratory involvement. Angioedema, mild reaction, it's mild. And anaphylaxis, it can be very severe, including up to causing airway obstruction. Mental status, mild allergic reaction, normal. Anaphylaxis, all signs of shock, right? Anxiety, confusion, decreased responsiveness. Lungs, in the mild or scattered wheezing. And anaphylaxis have significant wheezing in all lung fields or no air movement at all if it's progressed far enough. Vital signs, mild allergic reaction, normal. Anaphylaxis, hypotension, tachycardia, tachypnea, respiratory distress. All right, and then in GI, for your mild, it's going to be nausea and increased peristalsis. It's going to be, maybe a little bit of diarrhea or rumbling. And then anaphylaxis is going to be nausea, vomiting, and diarrhea. So hopefully our patients are going to wear some kind of medical identification jewelry that identifies an allergy, so we see that and we're like, oh, hey, there it is. But they don't always. They may have an EpiPen auto-injector. They may have, a duodote, twin inject, or an AVQ that walks them through the device. But whatever it is, if you see this, try to find out if they have used it or not, because that may play an important role in what you expect to find with this patient. Right, so your signs and symptoms: peripheral vasodilation, increased vascular permeability. That's from that mast cell and basophil activation. Right, histamines, all that fun stuff. Constriction of the bronchioles and the GI muscles. Itching, hives, edema, urticaria. Distributive shock, anaphylaxis, and to a degree some hypovolemic shock. And then potential for airway obstruction. Now, so management here. High flow oxygen, all right, if their ventilations are adequate. If they are not adequate, we need to BVM them. All right, we're going to give epinephrine by protocol. For adults, that is typically going to be 0.3 to 0.5 milligrams of 1 to 1,000 IM. For pediatrics, usual dose is going to be 0.01 milligrams per kilogram of body weight, up to your 0.3. Once again, by protocol, so you may or may not be able to. Some places will also let you use EpiPen, which would be fine as well. We're going to start an IV. If they're hypotensive, we're going to give them some IV fluids to try to increase that blood pressure to a perfusing amount. Right? Up to 50% of that circulating volume can be lost in the first couple of minutes of anaphylaxis. So they're going to need some careful reassessment and some fluids there. We want to consider some nebulized albuterol. Now, if they have significant hypotension or significant airway edema, talk to med control first. But typically, this is going to help reverse those bronchospasms, and it's going to help open up the airway. In fact, one part of the problem, which is not enough oxygenation. All right. And if your protocols allow, antihistamine, Benadryl, diphenhydramine can be used to prevent additional histamine from binding with the histamine receptors, which is what's causing our increased capillary permeability. The usual adult dose is going to be 25 to 50 milligrams and can be given IV or IM. And the pediatric dose is usually going to be 1 milligram per kilogram, up to 25 milligrams.